always be a kind of a
So Dr. Tushar Maniar is head of department, Nanavati Hospital, Pediatrics, and of course, he is associated closely with Dr. Tanu Singhal. So I couldn't find a more appropriate person to start the interview. So he has some topics. So the flow will be, he'll ask you questions, you will answer, and we will have some audience interaction in between. The audience is requested to be patient because we'll cover most of the things that you want to be said. So we'll just be patient. I'm so sorry that some view is obstructing you, but we can't stand, but you can stand.
So, as in the August gathering of predominantly adult physicians, both of us, we started calling ourselves unadulterated physicians. Okay. Now she has got a bit adulterated, so we accept that. So what we decided, Tushar and me, what we decided was that we'll start with a couple of diagnostics which are important, and then we want to discuss disease-wise antibiotics. And we thought we'll keep it in between, like I will ask pediatric questions and then he will pitch in with whatever adult supplement that he would prefer to ask. So can we talk about urine culture? So, because most of us, at least in pediatric, find it extremely difficult to convince parent to, first of all, get a urine culture done itself. So if you can tell us what is the best way to collect the culture and when we should be asking for urine culture.
So taking your second question first, when should we ask? So we should ask for a urine culture only if we have a reasonable degree of suspicion that the patient has a UTI. Because if you start sending cultures in any patient with fever, like suppose a patient comes with fever, cold, cough, then you know that the symptom is localizing to the upper respiratory tract. So there's no point doing a urine culture in that situation. So in children, we normally ask for urine culture when a child is just having high fever. And we must remember that children will not have urinary tract symptoms, like they will not complain of dysuria or something. So high-grade fever without any localization is when we would ask for a urine culture in children. The second point is that urine culture should always be interpreted with the urine routine. So urine routine, and sometimes, in adults, you may do sequential, like you may do a urine routine, and then if it shows pus cells, then you go ahead and do a urine culture. In children, because the process of collection is quite difficult, sometimes we tend to send both of them at the same time. So in children, actually it's only older children, if they're like more than 4 or 5 years old, you can ask them for a midstream specimen because they will cooperate. But younger children, you have to either do a clean cat specimen. That means you have to tell the mom that, she keeps the container ready when the child is fed and then collects the specimen, or she, feeds and strokes the back and collects the specimen. Now, if you are doing a urine routine alone, then a bag specimen is fine. That is okay for a urine routine alone, but not for a culture. Then you can even apply that bag and collect it. Now, sometimes it happens that, in children where we have a very high index of suspicion of UTI, so high fever, white cell count is high, CRP is high, then we often, if we are not able to collect a specimen by these methods and we need to start an antibiotic, we sometimes do a single in-out thing. That means you clean the genital area, put a feeding tube, collect a specimen, and send it for both routine and culture. That is for hospitalized patients where you have an urgency because you must start the urine culture before starting antibiotics. Suprapubic aspiration, actually, we have stopped doing. I mean, it's quite, traumatic, and also, it's written all where in textbooks, but, sometimes if you get blood or something, it becomes quite messy. So instead of suprapubic, I would prefer the catheter method, the feeding tube method.
So for urine collection bag, it's a simple 25-30 rupees sterile bags available, which are more like what you are used to colostomy bags. So they are as much smaller bags with an opening, and there is a sticker which you can peel it off and you can attach it to a boy or a girl, and then you can collect it. It's easier said than done because it still leaks and sometimes there are issues. How urgent it is for an OPD patient that we have to start an antibiotic for urine? Should we wait for a culture report? Should we
So, I think the routine is the most important thing here, because your routine report, one more important thing is that for both routine and culture, you have to send the specimen quickly to the lab, because even routine can get if it lies around, the white cells can die. So you may not be able to pick it up. In culture, you know that the bacteria multiply every 20 minutes. So if you're not able to send the urine culture to the lab immediately, you must refrigerate the urine specimen so that the growth stops. So that is one important thing. But I think your decision to start antibiotics is based on the urine routine report, which you can get within an hour or two, if possible. So if you have a likely clinical setting and you have a urine routine which is showing significant pyuria, which is defined as more than 5 cells per high power field of centrifuged urine, then you can start an antibiotic and then wait for the culture report to come. But again, you must understand that you can see pus cells in urine in other infections also. So if you have a child who's having high fever and cold and cough, you will have pyuria, which is called as febrile pyuria. So that is not an indication for you to start antibiotics. So the clinical setting is very important, that you have that clinical setting of UTI, then you see pyuria, then you know that you could be dealing with a UTI, and you would start antibiotics rather than waiting for the urine culture report, because in those 48 hours of delay, your patient may become so toxic that he might need hospitalization. So an illness which you could have treated on an OPD basis will now need inpatient admission, and damage to the kidney also happens.
Sorry, we have a major problem of contamination when we collect the urine urine culture. So how do we, when we see a culture report, what do we read, and when do we say this is likely to be a pathogenic organism, contamination?
So first is you have to see whether you're getting a single organism or 2 organisms. If you're getting 2 organisms, then it is a contaminated sample. Then there is no point trying to find out which is the pathogen. Yani if the colony count of one is more than the other, you really can't rely on that. So 2 or more organisms means it's a contaminated specimen. So it should be a single organism. Then the second thing is the colony count you have to see. So the colony count, basically the cutoff which we use is 10 raised power 5. So why do we use that colony count? Because, a lesser amount of bacteria can be seen just because of contamination from the perineal area when the child passes urine or the adult passes urine. Therefore, lower levels of colony count are not significant, though it's not that they're not important, and I'll come to that now a little later. So if you have a colony count of more 10 raised power 5 more, then it is a significant colony count, and then you would consider it important. But, if you have, let's say, a woman who is having very frequent urination, let's say she has cystitis, I'm just covering the adult part here also. So then you are voiding so frequently that you may not get a significant colony count. Second is that if your patient has already taken a dose or 2 of antibiotics, they may be having a UTI where your colony count may be not 10 raised power 5. Then if you have done a catheter sample, then 10 raised power 4 is the significant value. And if you have done a suprapubic aspiration, then any bacteria which you find is significant. So there are exceptions to the 10 raised power 5 rule also. On the other hand, so you can have a UTI with a non-significant colony count, and you can also have no UTI with a significant colony count, which we call as asymptomatic bacteriuria. That is, you have a 10 raised power 5 colony count, but that is just there, and it can even happen if your sample has not gone to the lab immediately, because from insignificant it will become significant. So you have to, so these are the, dilemmas or exclusions or exceptions. But 10 raised power 5 single organism would make you feel that it is significant.
Anything to say how quickly we got the culture positivity, whether we got it positive at 48 hours versus some lab will say later on?
No, it is not really important. That may be important in blood cultures. So if your organism is growing after 48 to 72 hours, it may be a contaminant, but that's not applicable for the urine culture. In fact, in most labs, you will get to know by the next day only. You'll see that the urine is growing on the plate. The colonies are growing on the plate.
Sure. What is the drug of choice that you advise for an outpatient urinary tract infection patient?
So this is for a child,
For
isn't
a pediatric,
For a
yes.
child. awaiting the culture.
culture,
So
yes.
we must understand that the common organisms which cause UTI in children is E. coli. Rarely you can have Klebsiella, Pseudomonas also, but E. coli is the commonest organism. And what has happened over the years, that your E. coli has become resistant to your cephalosporins. In fact, you must be seeing so many urine culture reports where the organism is resistant to cefexime, which used to be our drug of choice. But I think to begin with, I mean, in a child who's not very sick, I would either start coamoxiclav or cefexime as a drug, pending the urine culture report. But we must understand that you may have some patients who are resistant to these drugs, where you may have to change later if they are not better. Or sometimes you find that even though their bacteria, which has grown, is resistant to this drug, clinically they get better. That is often you have seen, that you've started an antibiotic, patient gets better, but when the culture report comes, you find that it is resistant. And that is because your antibiotic is concentrated in the urine to such a great extent that it overcomes the resistance. So in that situation, you would not change if the patient is clinically better with that antibiotic, but you have to watch these patients because sometimes they can have late therapeutic failure. Means initially they get better, but after 5-7 days they start running fever or they have an early relapse. So ये episode ठीक हो गया, after you have stopped antibiotic, within 15 days they will come with another UTI, and then you will have to treat on the basis of the culture report.
Sure. So now you have a child, depending first UTI, apart from urine routine and culture, what other investigations do you think we should mandatorily, which should be mandatory for the patient?
So in children, if they have a UTI, it means that they may be having an abnormality in their urinary tract. So you should not just leave that urine in UTI as such. You have to at least do an ultrasound abdomen for the child. Ultrasound KUB, sorry, so that you know that, yes, if there is any abnormality in the tract, then you can investigate these people further, because what you're really looking for is hydronephrosis or hydroureteronephrosis. And that, if you find, then is an indicator that you have to go ahead with other investigations like an MCU or a DMSA scan. But if your ultrasound is normal, then you don't need to really go ahead with these invasive investigations like MCU. You can teach the parents for techniques to prevent recurrent UTI, like avoiding diaper use properly, those things, avoid treating constipation, because constipation is a very important cause of pediatric UTI. And then if the child gets another UTI, a second UTI, then you know that you need to exclude reflux.
And there is no difference whether it's a boy or a girl, right?
So girls technically have more, if girls are more likely to get UTI in the first couple of years of life, because of the fact that their anus and the urethral opening are very close together. Boys have less. So if a boy gets a UTI as an infant or a young, then you are more likely to have a structural abnormality as compared to a girl. In fact, there are some people who say that if a child gets a UTI in the first year of life, you must go ahead and investigate, do a MCU or a DMSA, even if the sonography is normal.
Yes. DMSA, basically MCU is basically when you have to control the infection, and then only we go for MCU, if at all. For DMSA, we generally keep a gap of 3 to 4 months before we do a DMSA scan, and that's a scan which is done by giving radionuclide IV through the IV and taking pictures on the radionuclide scanners. And we wait for 3 to 4 months because we want the scars to be visualized or seen on kidneys. Yeah.
So the message is that don't leave a pediatric UTI after treating it. Follow up these children, because if you don't do this, if you don't investigate and you don't prevent recurrent UTI, many of these children, when they become adults, they'll have problems of hypertension, reflux nephropathy, chronic kidney disease, renal failure.
And sometimes even just growth failure can be there, because that could be the only sign for a child who's developing a renal failure.
In fact, this applies even to adults, because when you have an adult who has a UTI, you always would, especially elderly people, you would check whether they're having a post-void residue, whether their diabetes is well controlled or not, whether they're having underlying constipation, because recurrent UTI is a very common problem even in adults. And there also you have to go behind the cause, because if you don't treat the cause, these patients will keep coming every month or so with UTI.
You want to ask adult part and then we go to the next disease? Or okay. Any questions from for UTI? Do you need a mic?
No, you collect.
Just, sorry, I'll repeat the question so that it is recorded there and everybody hears the question. You asked that the method of collection for? No.
No, it'll have to be in 2 bottles because.
She's asking if the culture bottle can be used for a urine routine examination also, so
Yeah.
there is only one collection.
But the problem is that the moment you open the culture bottle, take a specimen for routine, you might contaminate it. So ideally, it is best to collect in 2 bottles, but both of them should be the sterile containers. And because in children it is difficult to keep collecting specimens, you sometimes do both together. If you have got a good clean cat specimen, then you would send the routine and culture both. But if your routine comes normal with no pyuria, you would not really give importance to the culture. That is very important, because otherwise you will end up treating many patients who may not have a UTI. So please, it is very rare to have a urinary tract infection without pyuria. It's very uncommon. Dip slides. So,
He's
yeah.
asking whether there are special slides to dip into the urine container. What is that?
They are called as dip slides, and the reason is that if you can't transport the specimen to the lab immediately and you're refrigerating the specimen for 12 hours, you are delaying your diagnosis. So then what you do is you just dip the slides in the urine. So it means you are inoculating it. And then, so that even if it goes to the lab late, it doesn't matter. And you have started the process of diagnosis immediately. Because you know it takes 48 hours to get a diagnosis. So you can use, if dip slides are available, you can use them.
Yeah, ma'am. She's asking if we should do creatinine levels in pediatrics.
Yeah, I mean, if you have a hospitalized patient with a severe UTI, we always do a creatinine test. Some of them may have a high creatinine during the acute phase, which may be due to dehydration also or this, and you would do it. But for an OPD patient, for the first UTI, you don't generally ask for a creatinine report in the blood. Yes, then you would do. In fact, in those patients, more important than the creatinine is the urine protein creatinine ratio, because that would be an early marker of reflux nephropathy if it is developing in the child.
He's asking in urine routine, presence of nitrites or presence of bacteria, vis-a-vis presence of pus cells. How important is that?
Yeah, so it's a good point. So when you interpret the urine routine, please don't look at just the WBCs. Look at nitrite also. So basically nitrite is highly specific, though it's not very sensitive, because if your nitrite is positive, it is highly predictive that your patient has a UTI. Similarly, leukocyte esterase goes hand in hand with the WBC. So if your WBCs are high in the urine, your leukocyte esterase will be positive. Bacteria present is an important thing, but then it also means that it should be fresh urine. Suppose your urine is lying for some time, a routine, and then you have checked for bacteria, you will always find bacteria. So presence of bacteria in a fresh specimen of urine is also highly sensitive for a UTI. So these things will have to be, if you have a urine routine where you have pus cells, your nitrite is positive, and it's a fresh sample and the bacteria are also present, then you know clearly that yes, there is a good chance that your patient has a UTI. On the other hand, if you just have pus cells, like some of these have like 5 to 10 pus cells per hypa field, but your nitrite is negative and there are no bacteria seen, then you have to start wondering whether this could be some other cause for the febrile pyuria. So you're very correct. You have to look at everything. And sometimes you have these bedside sticks. which you can do in your OPD only, where you can get the nitrite and the leukocyte esterase, because these are all based on the strip. Then you don't even need to wait for the lab report. You can look at the leukocyte esterase nitrite and decide whether you want to start antibiotics. So they help in point of care diagnosis of UTI.
He's asking which is the best time to collect for culture, urine culture.
When you're suspecting a UTI, you have to collect. You don't have to collect an early morning specimen or anything. It is at that time, because you have to submit it immediately.
Dr. Kiran Desai? Just a second, sir.
Can I
ask for MCU and DMS as far as further investigations are concerned? Any specific thing you advise for adults over and above this?
No, so in adults, we would not do MCU or DMSA scans. In adults, basically you would do a ultrasound post-void residue. You would also do a uroflowmetry. These are the two other investigations which you would like to do if you have a patient who is coming with recurrent UTI, and you would do an ultrasound KUB also, because you want to check if there's some obstruction somewhere. So I think these are 2 or 3 of the things which you would do in adults.
Madam,
Dr.
एक
Merchant?
minute, Tushar bhai.
Yeah, sorry, he's continuing.
In urine routine, there are so many reports comes like pus cells absent, but at the end they have written lot of bacteria present.
So
What
that
should-
may be because of either the specimen was out for a long time, therefore your pus cells have gone and there are a lot of bacteria. That is usually the possible reason.
Dr. Merchant? What about?
So
What about
pyuria,
pyuria without culture positivity?
so that may happen if you have a UTI and your patient has already received antibiotics. Sometimes what happens is patient has got admitted, they've given the first shot of the antibiotic and then collected the culture. Or there could be an alternative cause for the pyuria. You have to remember, sometimes sterile pyuria, you have to even think of genitourinary tuberculosis. So these could be the various reasons, but the gold standard is actually the culture. The gold standard is the culture, and if your culture is negative and your patient has not taken any antibiotics, then the chances are very high that you're not dealing with a urinary tract infection. The other way is more common, that you are having no UTI and yet your culture is positive because of contamination or something.
Okay, sir. Sorry, any difference? So he's asking leukocytes in the urine are same as WBCs in the urine?
Yes.
Or pus cells also, same thing?
Yes. And there are 2 ways by which labs report leukocytes in the urine. One is they report per HiPA field, so that is a centrifuged urine. And the other is they do a count in the Newbar chamber or something, where they just mention WBCs, the count, like sometimes you see 57 count or you see 100 count. So that is, and for that, that is uncentrifuged urine, and for that the cutoff is 10. Anything more than 10 is significant.
Sir? Sorry? Boric acid container for collection.
No, I don't.
He's
Okay.
saying for people, as some people used to do that if patient has taken antibiotics, they would have special containers. Is that right?
No.
Boric acid containers.
If the transport's going to take longer, then there was a concept that you can have boric acid to prevent further multiplication of bacteria.
Okay.
But I don't think.
I'm sorry, I don't know. I'll check on it and get back.
Is it possible
Yes.
that in MCU,
Yes. Because patients who have a reflux will not keep having a UTI all the time. Na? So, and you actually do an MCU once the infection is corrected. So what is very important is that if the patient has a reflux, you must not ask for monthly urine routine and cultures, which is sometimes the practice. Patient is having a reflux, so as part of monitoring that, they say every month you do a routine and culture. That is not recommended. Even if the patient has a reflux and is on prophylactic antibiotics, a urine routine and culture should only be done when the patient has symptoms. No, but you would not do an MCU in a patient who never had a history of UTI, na? You would do an MCU only if the patient had a past history of UTI.
or if you did an ultrasound for any other reason and you've picked up,
We'll do it in the break with her. Yeah. Individual cases we can ask later. Yeah.
Sorry?
How do we collect or interpret urine routine in a catheterized patient?
So that's a very good question because you have this problem of COTI, catheter-associated UTI. So one must remember that the culture should never be collected from the bag because the bag is constantly growing. So you can either collect through a separate port because you have different catheters which have a separate sampling port from which you can collect the specimen, or you can put a needle into the tubing and then aspirate the urine. So though it should be collected like that. And of course you have to be careful because your patient will always have bacteria. You will also have some pus cells as well because of the catheter-induced cystitis. So it is common to find pyuria and significant bacteriuria in catheterized patients. You have to really interpret it carefully that, if a catheterized patient is having fever and there is no other cause of fever, then you must look at the urine. Because just don't go and, and there are many patients who are on catheter, they just ask for, every month a urine routine or culture karalo. That even if you find pus cells, even if you find bacteria, it should not be treated. Because the patient is asymptomatic. So in a patient who has a catheter, only indication for treatment is symptoms. If there are no symptoms, you should leave it alone because if you keep giving antibiotics to these patients, their bacteria will become more and more resistant. And then when they actually have a true UTI, then you will not have antibiotic options to treat them.
We'll take the questions later. We'll
yes,
go
one more point.
Area that you should cover is...
Yeah, one more point I wanted to ask is, you mentioned about urinary antibiotic prophylaxis. So in pediatric, when would you recommend a prophylaxis and how long?
So it is reflux. So if you pick up a patient who has a vesicoureteric reflux, then you would give antibiotics and actually you would give it for at least 1 year. So if you have a patient who is less than a year old, then you will give it till the age of 1 year. Otherwise, in other patients, you would give it for 6 months to a year and then stop it. And you would use drugs like either cotrimoxazole or nitrofurantoin. Sometimes you have these patients who have a recurrent UTI, where also you haven't found a reflux, but they just keep getting UTI. Sometimes it is because of bladder bowel dysfunction, which is a common cause of recurrent UTI in children. There also you can give prophylaxis.
A little bit about the pattern of resistance in urine infection that we are seeing, ESBL, etc. Can you tell us, as a family physician, how do we look for resistance and how do we kind of overcome resistance with antibiotics?
Yeah, so the most important thing is you have to look whether if isolates sensitivity to ceftriaxone or a third generation cephalosporin. So if the report says that it is resistant to ceftriaxone, it means that it is an ESBL pathogen, basically an enzyme which is destroying the cephalosporins. So next you have to look at, is there any other, you're dealing with an OPD patient, not a hospitalized patient. So the next thing which you will have to look at is whether the isolate is sensitive to cotrimoxazole. Because many ESBL pathogens are sensitive to cotrimoxazole, so that would be the drug which you would use if cotrimoxazole is sensitive. Now, if cotrimoxazole is resistant, many times the urine culture will say that it is nitrofurantoin sensitive or it is phosphomycin sensitive. But we must understand that nitrofurantoin is only effective for cystitis. It is not effective for pyelonephritis. So if your patient is having a cystitis or a lower UTI and the patient is ESBL, then cephalosporin resistance, then you can use drugs like nitrofurantoin. I would not recommend using phosphomycin in these patients because phosphomycin is a very crucial antibiotic which the patient may need even if they get admitted with a severe pyelonephritis. So if it's cephalosporin resistance, you look at cotrimoxazole, you look at nitrofurantoin, and ciprofloxacin will invariably be resistant. I don't think you are actually seeing any report where ciprofloxacin is sensitive. The problem happens when your cotrimoxazole is also resistant and you have an upper UTI, means the patient is having fever, you're suspecting pyelonephritis. Then in that case, what antibiotic to use in an outpatient setting is a very important issue. So here, you have 2 or 3 options, though they are not the best options, but one option is to use cefixime clavulanic acid, which is the problem is that you don't have real data supporting cefixime clav, but you can try if the patient is not very sick. Many times your report will say that ceftriaxone is resistant, but amox clav is sensitive. Okay, but remember that if ceftriaxone is resistant, amox clav may not work, because sometimes an organism is sensitive on the report, but it may not work in the real life setting, because technically speaking, all ESBL pathogens are also resistant to amox clav. So you should not really go down the amox clav pathway. The other is pharopenem, because pharopenem is an antibiotic which has shown that it is sensitive to ESBL pathogens. But the main problem with pharopenem is that there are not enough studies, and there is no way to check for sensitivity in the lab. No lab can tell you whether pharopenem is sensitive or not, and please understand that pharopenem is not switch over, or it is not the same class as meropenem, imipenem. They are penems for sure, but that is a carbapenem and this is a different penem. So you cannot say, okay, you can use pharopenem in that situation, but you may or may not succeed. So, and then finally, if your cefixime clav does not work, your pharopenem doesn't work, then you will have no option but to go to injectable antibiotics, maybe like piperacillin tazobactam or cefoperazone sulbactam, etc. Aminoglycosides are often sensitive, but you don't want to give aminoglycosides in elderly people because of the other problems. So ESBL, urinary tract infection, is a difficult thing.
What percentage of E. coli you think in India are ESBL producers?
In community-acquired UTI, it is now 50 to 70%. I mean, that is it. The only issue is that many times you get away with your standard drugs, like because these drugs are concentrated in the urine, so you've started cefixime for the patient, and then you find that 48 hours later it's a ESBL pathogen, but your patient is already better. So, but if your patient is not better, then you have to use drugs like cefixime clav, or you have to use pharopenem, and if that is also not working, then you have to go to injectable antibiotics like maybe ertapenem or something.
The family physician typically uses cefixime in UTI, usually with clavulanate to begin with, not as a second thing. Is that okay?
That is okay, because the prevalence in pediatrics, the prevalence is lower, so it's okay for us to use cefixime. But in family, I understand in family practice, but have you seen failures with cefixime clav? Very less, yeah. So that is why I think that is the, okay, TDS.
We recommend 10 mg per kg.
Yes, so 200 mg TDS, yes.
Correct.
So maybe in adults you can use cefixime clav as your first thing, and please think of not to use pharopenem indiscriminately, because studies have shown that if you use pharopenem a lot, you may become carbapenem resistant. So you don't want, for a short-term benefit for your patient, for them to become carbapenem resistant and become candidates for colistin therapy if they have a bad UTI. So pharopenem has to be used very selectively, only for urinary tract infections, which are ESBL, and not for other infections like respiratory tract or.
There are some students here, so because we are mentioning ESBL frequently, some of you may want to know, ESBL, extended spectrum beta lactamase, is the full form of ESBL. Lactamase is an enzyme produced by bacteria like E. coli and Klebsiella. These enzymes destroy penicillins and cephalosporins especially, which are the beta-lactam antibiotics. And hence, these 50% or more, for example, of E. coli are producing ESBL. So in these, you have to add beta-lactamase inhibitors like sulbactam, tazobactam, or the OPD drug typically is clavulanate. So these are the beta-lactamase inhibitors. Yeah, Maniar.
What is, adults tend to give lesser duration for UTI treatment. What is the minimum duration you would recommend for a proven UTI in children?
In children, 10 to 14 days.
Even
Definitely.
Oral first UTI, uncomplicated in OPD also.
Yes, unless, and you don't see cystitis in children, it's uncommon. Most of them are febrile UTIs, that means they're upper UTIs. So you need to treat for 10 to 14 days, otherwise you will have a relapse.
Yeah. And you may see a KUB report in pediatrics, many of them saying debris and cystitis, but they will have fever, and so it's not just cystitis. So we need to make sure that we give full course of the treatment.
The message here is that differentiation between upper and lower UTI is not just based on the symptoms of cystitis. Presence of fever usually marks any UTI as upper UTI. And we know that lower UTI and upper UTI are often coexistent. So fever means upper UTI.
Any other things on UTI? Otherwise, we'll go to the next.
We have discussed UTI with Dr. Vasant before, so that's why I'm not discussing it again.
Fine. Shall I take rabies vaccine now and then move on to something else?
That's perfect.
So we chose rabies vaccine because all other vaccines are not always practiced by the family physicians, though they should, and so we are focusing on rabies because it's used for pediatric as well as adults. So can you tell us briefly what is the current schedule that we recommended in India for first exposure?
So basically the first thing is that you have to demonstrate the category of the bite. So there are category 1, category 2, category 3. Category 1 is just a lick on intact skin. So that is something which doesn't merit prophylaxis. Category 2 is a scratch or something which has not raised blood. Now if you actually look at any kind of bite, you will rarely see a bite which has not raised blood. So for practical purposes, most of the bites are category 3, where you have some blood which is also seen, even if it is a tiny thing. In fact, in the US, they don't have anything like category 2 or 3. They have either you give prophylaxis, which is full, which is the immunoglobulin plus the vaccine, or you don't give anything. It's only in India, you know, that you have a situation where in category 2, you only give the vaccine. But most of the times, it is always safe. If it is a stray dog bite, then and I'll come to a pet dog later, because sabse zyada issues are now with pet dog bites. What should you do in them? So in stray dog bites, you have to assess the category, wash the wound with a lot of soap and water for 5 minutes. That is very important. And then most of the times you have to give both the vaccine and the antibodies. Okay. Now, earlier, you know, we had this only human rabies immunoglobulin which was available. And that was 20 units per kg is the dose, to a maximum dose of 1500 units, which you have to infiltrate locally around the wound. So earlier, if you look at the recommendations, they would say that whatever you can infiltrate locally, you infiltrate, and the rest you give intramuscular. But now the guidelines have changed. They say that use whatever you can locally, but there's no need to give intramuscular, then just leave it. Don't use, because it is of no use. So that is a change in the guidelines. The other thing is that now you have monoclonal antibodies also available against rabies, which are cheaper, because human rabies immunoglobulin is always not available, and for adult it would cost about 25,000. So you have two types of monoclonal antibodies available. One is called as rabies shield, and the other is called as twin rab. Okay, rabies shield is produced by Serum Institute of India, and it is towards one epitope, and the dose is 3.3 units per kg, and you have 100 unit vial available, and you have a 250 unit vial available. So the good thing about it is that you can infiltrate, the volume will become small, so you can infiltrate it locally. And the other antibody which has become available is called twin rab. Twin rab is from Zydus, and twin rab has antibodies which are directed against two antigens. So technically it is probably better. Usme the dose is about 2400 international units, and the cost of rabies shield will be about 3,000 to 4,000, and the cost of twin rab will be about 5,000 to 6,000. So they are much cheaper as compared to the human rabies immunoglobulin. Because earlier the cost of the HRIG was a major impediment. So you can use these monoclonal antibodies for local infiltration if it's a category 3 bite. And then you have to also give the vaccine. And the vaccine, you have the cell culture vaccines available, you have the human diploid cell vaccine available. I think nowadays most of us use Zuvir-Rab because some of the others like Rabipur, Viro-Rab are not available. So you have to give the vaccines day 0, day 3, day 7, day 14. Now, the international guidelines have taken away the day 28 dose. So 4 doses are 0, 3, 7 and 14 is what you have to give intramuscular, and it is very important that it is given in the deltoid and not in the gluteal region, because in gluteal region there is so much subcutaneous fat that seroconversion will not occur. So in fact the guidelines say that if somebody has been accidentally given it in the gluteal region, the vaccine, you have to repeat the dose. Hepatitis B and rabies are both vaccines which should not be given in the gluteal region. So you, for post-exposure prophylaxis, this is what you do. Now, if the patient has already received vaccine in the past, which many of your patients have, then they don't need the immunoglobulin or the monoclonal antibodies, and they just need 2 doses of the vaccine on day 0 and day 3. And then finally the pet dog thing, you must, that is a big issue, because people, so what we actually recommend first is that if you are going to keep a pet, please take pre-exposure prophylaxis. Okay, that means if you're keeping a pet, then make sure that all family members have received pre-exposure prophylaxis, which is now a simple schedule of 0, 3 and 7, 3 doses. And then, because if they even, now what do the guidelines say about pet dog bite? If you look at the guidelines, they say that even if the pet dog is vaccinated, you have to go through the full schedule because of 2 reasons. One, you don't know what is the efficacy of the vaccines which have been used in the pet. And second is, unless you have an antibody level in the pet available, saying that it is in the protective range. So we say that even if your pet dog has bitten you, you have to go for the full prophylaxis. That is why having the pre-exposure prophylaxis is very important, even if it is a pet dog. Huh? Pre-exposure prophylaxis is for life. That means you will never need the antibodies, but you will still need the 2 doses of the vaccine only in the first 3 months, because sometimes, you know, they have a pet dog. Abhi unhone pura schedule liya, 2 mahine baad fir se bite ho gaya. So that cutoff is 3 months. So within 3 months of a post-exposure prophylaxis or pre-exposure prophylaxis, you don't need to take the day 0 and day 3 dose, but after that you need to take the day 0 and day 3 dose. Subcutaneous is not recommended. There is intradermal. Intradermal is done in the clinics by the government to save on the vaccine. But in private setup, we should not do intradermal because we are not expert at doing it. For doing intradermal, there are some requirements which have to be met. So we should not practice intradermal injection. We should give intramuscular.
There's usually an excuse or tendency to say my dog is vaccinated. So can I just take the vaccine and not give the immunoglobulin? Is there any science behind that?
See, it's a difficult situation because sometimes what happens is that these pet dog bites are on the little bit on the face or on the finger, where infiltration of the immunoglobulin also becomes difficult. But the issue is that medico-legally now you have to still recommend, because the guidelines are not different for pet dog versus stray dog. So then it is up to the patient whether they want to take it or not, but you must recommend to be medico-legally safe.
Yeah, and if you read guidelines, please make sure you're following Indian guidelines, because rabies is endemic in India. What is recommended by CDC is going to be very different for pet dogs versus what is recommended here.
Sometimes there are questions like, a rat has bit me, do I need prophylaxis? No. So basically rats are not known to transmit rabies in India, so you don't need. Sometimes my turtle bit me or a bird bit me, so they don't need prophylaxis because rabies is a disease of warm-blooded animals. So pigeon, some bird bite or turtle bite, all the cold-blooded animal bites don't need rabies prophylaxis.
But cat bite does need, right? Because a lot of
cat
people
bite,
have
monkey bite. Monkeys
bite.
are also
the two.
carrying rabies in India. So these are 2 which you have to recommend.
Sorry?
Nail scratching is not recommended. I mean, if you read, they say that suppose the dog or cat is having rabies, then they will suck their paw and then they will scratch with a nail. But it's very far-fetched. So normally the problem happens is that sometimes a child may not be sure whether the scratch was with a nail or was it with the tooth. So in children that is a problem because they may not give a good report. But if it's an adult who says that it was a scratch by the paw, then you don't need to give anti-rabies prophylaxis.
Suppose somebody gets bitten today and is traveling, comes back after a few days to you, till how long should we recommend rabies vaccine, and till how long can we give immunoglobulin stroke antibody?
So you have to treat that patient as if he's had it today. So even if he comes back after 7 days, you have to do both the rabies vaccine plus the immunoglobulin. The only thing is that if he has taken 1 dose of the vaccine, and if 7 days have passed, then you can't use the immunoglobulin, because what happens is that your antibodies are automatically produced by the vaccine, and the immunoglobulin may actually act as a negative feedback to the vaccine. So if he has not taken the vaccine, even if he's coming after 15 days, you have to give you have to treat it as a fresh bite, because you don't know how long the virus has actually remained in that area. It may remain there for years. In fact, there are cases of rabies with an incubation period of 7 years also. So you have to treat it like a fresh bite. You have to recommend both the immunoglobulin and the vaccine. I mean, when I said immunoglobulin, I mean antibodies. Yeah.
He's asking if
what
what
is
the
that?
antibodies
Have we
have
shifted? So actually, sometimes the patients itself say we want the best possible thing, so then we give the immunoglobulin. But otherwise, if you look at the guidelines, they have shifted to the antibodies. So we give the antibodies because it is technically easier to give and it is cheaper.
He's asking if you can guide them more about the monoclonal antibodies.
Yes.
which
So
are-
wherever I said immunoglobulin, you can put monoclonal antibodies there. You can use rabies shield or you can use twin rab. Technically speaking, twin rab seems better because there are two epitopes to which the antibodies are produced. Absolutely.
Absolutely.
Yes. So that's a good question. That if it's a pet dog and then your animal is alive after 7 days, then do you really need to complete the schedule? So if you've taken 0, 3 and 7, then you can stop, because you have actually converted the post-exposure to a pre-exposure schedule. But you must give the 7-day dose. If you have just given day 0 and day 3 dose, the patient hasn't come for day 7 dose, they come at day 10, they say, my animal is alive, should I take the 3rd dose? The answer is yes, because then you have a pre-exposure schedule in place. So whenever this patient has bite later, then you can just give day 0 and day 3 dose. If he just took 2 doses and left it, then you have to repeat the full course again. And you have to tell your patient that whenever they take the vaccine or whatever, they must keep a copy. Because if you have a patient who comes to you and say, I've taken 5 years back, but you have to say that, give me proof. If they are not able to give you a proof, then you have to treat it like a patient who has not been vaccinated, because there is no record. We don't know whether he took 2 doses, whether he took 3 doses, we don't know that.
Sir, how long does pre-exposure prophylaxis in a patient with a pet
Protection last.
last?
It does not last for more than 3 to 6 months, because people who are like working with rabies animals, they take a booster every 6 months. No, because then you would see, the purpose of pre-exposure prophylaxis is basically to avoid needing the immunoglobulin. So then what you would do is, suppose a person is working in the lab with the rabies thing, then you would give every 6 months a booster. In the other patients who have taken pre-exposure prophylaxis, whenever they have an exposure, then you would give them day 0 and day 3 dose. So that is, there is nothing like, if you have taken pre-exposure prophylaxis, you will not need the boosters later. Those 2 doses you will need. Yes.
That's right. It's lifetime.
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 The only exception is if your patient is immunocompromised. Because suppose you have a patient who is having multiple myeloma, who's on steroids, who's on cancer chemotherapy. Those are the kind of patients where you would have to give them maybe the immunoglobulin also and the full course, because they will not have enough memory cells to produce the antibodies.
A quick question to you. How many of you have pets? Okay. How many of you who have pets have not taken the pre-exposure prophylaxis? Have not taken. You have not. 2 of you have not taken. So that is one thing that you take away today, that you have to take your 3 doses of pre-037. With the increasing number of pets, pandemic especially, are you seeing an increasing number of rabies?
No, actually, most of the people who come to us are those who have had pet bites. Because, जो stray dog bites होता है ना, they are the kind of people who are more of the lower class. They would go to the government clinic. So mostly what we are seeing is pet bites, but it is a problem because you have to again keep giving
I'm
them.
saying, are you seeing rabies?
No. So most of the times I think these pet dogs are not transmitting rabies, but because rabies is 100% fatal disease, you have to be very cautious. You can't, many times what we actually see are bites by pets who are not vaccinated just because they are puppies. You know that you can't start rabies vaccine for I think 6 weeks or 3 months. So many times these people have got a pup home who's just 6 weeks and not rabies vaccinated. So if that is the case, then you have to go through the whole thing because the pup is unvaccinated. And you don't have details about the mother, that the mother was vaccinated or not, otherwise there would be transplacental antibodies. So that is why if you have getting a pup home who's not vaccinated, it is all the more important that people take the pre-exposure prophylaxis.
May I just summarize? Hiren, yeah.
So vaccine should never be given in the gluteal region. It should always be the thigh or the deltoid. Deltoid is the best place for all vaccines.
Not for infants, you're saying? For infants, you can give in the thigh, anterolateral aspect, not in the gluteus. But as you said, the earlier you give it on the deltoid, better it is.
So only till the first year you need to give it in the thigh in children. After that you go to the gluteal region, the deltoid only.
Also, you must remember as adult practitioners, when any bite occurs, make sure your tetanus protection is complete. Because most of the time they'll come for rabies protection and not come for tetanus protection. One more thing, as Dr. Singhal said, there will be a lot of excuses saying my puppy is 3 months old, he has never gone out of the house, has never been exposed to other dogs. But medico-legally, it is mandatory that we advise full protection.
Dr. Rathod? What is the risk to us?
Yes. So it's very low. Rabies is not transmitted by the airborne route. Rabies is transmitted more by very close contact, droplet or contact. So if you are, actually many times this happens that there's a patient you have seen and then later on you come to know that the patient has actually had rabies. So if your contact was not intimate, like you didn't do any intubation or some very close contact, you don't need any prophylaxis.
Do you think everybody sitting here should take pre-exposure prophylaxis?
I think, there is at least, because especially if you are the people who go for morning walks and you have a lot of stray dogs and cats in your society, it's a good idea to take pre-exposure prophylaxis. In fact, IAP has recommended that children, especially children, because you see these children, they are unsupervised. They go around feeding cats and strays in the compound, and many times they have a bite which goes unnoticed and unreported. So there is a move that, whether we should start vaccinating children also for pre-exposure prophylaxis if there's a high thing. So
Any questions on rabies? I'll repeat the question so that.
Absolutely, yeah.
She's asking whether if you have taken a post-bite 03714, then second bite only 2 doses, which is correct. Only 2 doses after the second bite, right?
No, for life.
For life.
For life.
And no immunoglobulin for life.
In fact, unless, because it is counterproductive. Somebody would say, no, I want to take the immunoglobulin also if I've been previously vaccinated. If that patient is immunocompetent, giving that immunoglobulin may actually hamper his own body's immune response against the vaccine, because the immunoglobulin exerts a negative feedback.
Dr. Anuj?
Very safe, because now we don't use the nerve tissue vaccine. So maybe apart from a little bit of pain or at the injection site or a little bit of fever, no serious side effects.
He's asking how many cases of rabies have been recorded in the city.
So we in India have about 25 to 30,000 cases per year, which is a large number, you know. And even in Bombay, like I have seen, you know, cases every 3-4 months you hear of one case. In fact, there was a young police woman who was just 22 years old. She was outside a police station, bitten by a dog, didn't go and take prophylaxis, then developed rabies, was admitted in Jaslok. And you know, then you, I mean, you are, because there have been only 7 or 8 survivals reported after rabies. And those people have serious neurologic side effects. But yes, if a person has been partially vaccinated, like they just took the vaccine, they didn't take the immunoglobulin, they are the kind of patients who may survive, but they are left with severe sequelae. But we hear about them all the time. Every 2-3 months we have one case.
Has Nanavati seen cases of rabies?
Not to my knowledge.
No, we have had at least 3 or 4 admissions.
At least pediatric we have not seen.
He is, say, from outside
Brand
Mumbai.
interchangeability.
You can interchange if
Brand?
that particular brand is not available. And you must see that the rabies vaccines are mainly 3 types. One is the human cell culture, the second is chick embryo, and the third is viro cell. So there are 3 categories of rabies vaccines. Ideally, you should see that if the base is the same, but even if that is not the same, because the priority is more to give the vaccine than to run after the brand. It is more important that the vaccine goes in.
So
Dr. Devesh? He's saying after second bite, you have to take only 2 injections. Is this lifetime? Or
Lifetime,
it is
lifetime. Even if somebody has received the pre-exposure prophylaxis 20 years ago or a bite 20 years ago and he comes after 20 years, only 2 doses.
So what I tell my patients is whenever you take a rabies vaccine, because all of them will have their routine vaccine chart. If at all you take rabies vaccine, please take a picture and email it to yourself. Because in today's world, that is the one thing which will be there with you always. You can just search it on Google, show it to your doctor, and you will be prevented from taking an immunoglobulin. Not only cost and pain, but as Dr. Singhal said, you will prevent yourself from getting a negative effect of taking an immunoglobulin.
No, but I mean, but if you're taking post...
Immunoglobulin का क्या करेंगे फिर?
Huh.
You will save on the immunoglobulin by taking pre-exposure prophylaxis.
No. I think his question is different. Whether it is, if you choose to take pre-exposure before you get bitten, then you don't have to take immunoglobulin.
No, but 03714 and 037 are equivalent.
Correct.
It's not that if you have taken 03714, you will have to take lesser doses in future. But वो तो is applicable even for 037, na?
Lifetime.
No, lifetime.
So
Yeah.
what Dr. Singhal said is, if you have taken any complete vaccine, pre-exposure or post-exposure, next 3 months, any bites, no prophylaxis required. If she says 6 months, I'm okay with 6 months. After that, whether you've taken 3 months,
But people who work with rabies,
they
think
take
every
repeatedly
6
6 months. Otherwise, 3 months complete protection. You don't have to repeat anything at all. If it is a 3-dose, 4-dose, full protection for life, anytime, no immunoglobulins, and 2 injections for the next subsequent exposure. 03.
03.
It's very simple to
Somebody, yeah,
remember.
coming,
I'll tell you one simple way to remember is, it's 0, half week, 1 week, 2 weeks, 4 weeks. It used to be like that. Now it is 0, half week, 1 week, and 2 weeks. And if you give pre-exposure, it is 0, half, and 1. If you give post-re-exposure, then you give 0 and half. So first 2, first 3, or first 4.
There is one more thing which you can do, that if your antibody is not available immediately, on the first day you can even give 2 doses of the vaccine. So you give 2 doses and then you try and see over the next 3 or 4 days how you can refer the patient for a antibody in the nearest area. And that is particularly important for stray dog bites and particularly important for bites which are on the upper limbs and face, because the risk of rabies is highest because the time it takes for the virus to travel to the brain is short.
And this situation will come most often when the patient is traveling. Has gone to a hill station or a small place and they get bitten by whatever animal, and you get a call that there is no immunoglobulin available here. So that's where this strategy works very well.
No, antibodies for every bite. Category 3 bite, it is there. But I'm saying that if you have an upper body bite, you have to be very, very quick in giving vaccine and antibody, you know, because there the risk is higher. So you have to infiltrate with a, around the bite. You have to just, like you would infiltrate a local anesthetic solution in the same way you would infiltrate. Subcutaneous.
Yeah. Okay, I'll just summarize because the questions are being repeated. Very quick summary. No bite ever. You give rabies vaccine, that's called pre-exposure prophylaxis. 4 doses instead of the previous 5 doses.
No, 3
Zero,
doses. 3 doses, 3 doses.
Sorry, pre-exposure I'm talking about. 3 doses, 0, 3, 7. 3 doses, 0, 3, 7. That means for life, unless you are immunocompromised, you will now need only 2 doses post-bite. And you will not need immunoglobulin, keep correcting me if I make mistake, and you will not need immunoglobulin post-bite. So 3 doses, 0, 3, 7, all of us, after we are bitten, which is category 2 or whatever category, after we are bitten which shows some blood, we have to, if we have taken prophylaxis before, take only 2 doses, 0 and 3. If you are bitten again after 2 years, we again take 2 doses, 0 and 3. Every bite you keep taking, maybe for the first 3 months, you will not need to take, right? So this is pre-exposure and thereafter. If you have taken pre-exposure, no immunoglobulin ever, unless you are immunocompromised. Now, if we have not taken any pre-exposure, you get bitten. Then you have to take your 4 doses, 0, 3, 7, 14, which is post-exposure prophylaxis. And you have to take immunoglobulin. If you do not get immunoglobulin within 3-4 days, then you have to take 2 doses of the rabies vaccine as the first dose, so that you tide over the immediate phase and try to get antibodies soon enough. About the immunoglobulin, my personal, what I do is I never give immunoglobulin in the OPD because of lack of expertise and experience. I will always refer those patients to an institute. But you can decide to learn. It's not difficult to learn.
Yeah, and Kokila Bain Hospital, we have a 24/7, animal bite thing. We have our emergency physicians who are really trained, and if you're not able to give the immunoglobulin or the antibodies yourself, you can always send them to the emergency of our hospital or maybe Nanavati hospital, and they will do the needful.
How many of you can keep rabies vaccine in your refrigerators if you give vaccination? Okay, so not the majority, definitely not the majority here. We have realized that after any talk on vaccination, the income of the GP rises by about 10%. So do keep vaccines. If you are practicing regularly, do keep the rabies vaccine, and I think that should be a good thing to keep. I'm not.
She'll answer.
Sent to the hospital.
See, you have to know how to infiltrate. If you are not knowing the correct technique of infiltration of the immunoglobulin and you are doubting ki how will I infiltrate 5 ml, because the volume comes to 5 ml in many of these even monoclonal antibodies, then it's better you send them to a person who is doing it on a regular basis, because they will do it properly. So, yes, as per
if the
rules,
dog is
yes.
vaccinated, if you have not taken pre-exposure prophylaxis, you still need immunoglobulin. As she said, we are not sure of the dog unless antibodies levels are done.
Pregnancy, any age, is not a contraindication to the vaccine. So even if the woman is pregnant, she can take both the immunoglobulin and the vaccine. And tetanus, just to add, 10 years if you have taken the tetanus vaccine, you don't need to repeat it. Okay, 10 years it's valid, the tetanus. And the third thing is about antibiotics, because if it's a major bite, then you get animal bite related infections. So you have to put these patients on coamoxiclav for 5 days. That is the antibiotic of choice. But if it's a minor scratch or a little bit, then you don't need to use. Otherwise, it's a large wound, you have to give antibiotics.
If you're giving tetanus as adult physician, please remember to use sorry, I don't want to use the brand, but we can use brand names, right? Boostrix or Tdap rather than TT, because it will give additional protection for diphtheria and pertussis for the next 10 years. So unless it's a pregnant woman who has already been given Tdap, then obviously the person is protected. So those who are not protected and you're giving tetanus, try to move on to Tdap.
But tetanus is given in adults every 10 years.
So Tdap can be given every 10 years now. Previously they were saying only one Tdap and not repeat ever after or go to TD. But now we say we can give, am I right? Yes. We can give Tdap every year.
So now even if a woman becomes pregnant after 3 years and she can take a repeat Tdap in that pregnancy.
So how many of you have a notice in your clinic which says all patients, irrespective of bites and injuries, should take tetanus Tdap or tetanus toxoid every 10 years? How many of you have a notice like that? 3 people, 4 people. So this is another way of improving income. Because it is an ethical, scientific way of improving income. Yeah. You must give every patient. So that means you're giving at least 50, 60, 70, every month, at least more injections.
Supplemental question. How many of you have taken Tdap in last 10 years? See, you have some money to spend on yourself also.
No, and to take this opportunity, you must, above 65 and people with comorbidities, the pneumococcal vaccine and the flu vaccine.
Yeah,
they are very important.
We'll be coming to that.
No, you can give Tdap earlier because the reason for giving Tdap in pregnancy is to protect the baby from pertussis. So you can give it.
But if you're giving, you don't have to give 2 Tdap to the mother. You can give only 1 Tdap and second can be a TT.
That is not good. That can actually cause hypersensitivity reactions also. You can see massive swelling and you may actually cause the antibody levels to go lower than better because if you give excess vaccination.
If I get a wound today, I take a TT today, I get a bad wound of rusted iron after 6 months. Should I take a TT again after 6 months? No, your TT is valid for, Tdap or TT is valid for 10 years. Provided?
Yes. Yes. So whenever you are vaccinating a person, you must take the previous history. So suppose somebody has not taken TT ever in their life, then that patient should take 3 doses at 0, 1 and 6. TD, TD, Tdap or Tdap, TD, TD. You can't take 3 doses of Tdap 0, 1 and 6. So that is, and then what you are saying is right, then it becomes applicable that every 10 years you would take.
I would highly recommend one full session on adult immunization with Dr. Singhal next time.
Absolutely. Every time surgery is done, TT is given.
So actually, that is completely false because you are doing surgery with clean instruments. How is that increasing your risk of tetanus? Tetanus comes from the spores which are in dirty instruments, etc., soil exposure. So that is wrong. That practice is wrong, yeah. But it's just that, you know, sometimes it gives an opportunity to update that patient's vaccination status if he has not received it in the past 10 years, yeah.
Okay, I'll ask her about the, so now the next area that we are covering is pneumococcal vaccination. And as she already introduced, and all of us are fairly familiar with pneumococcal vaccination, the adults especially, and therefore this might be quick. Approximate earnings in a GP who has about 20 patients a day. Calculation is that if you give pneumococcal vaccine indicated ethically to your patients, then your income will increase at least by 30,000 rupees per month. This is your first basic information, right? And we take on from there so that you can, the motivation is required. Because we are constantly looking for ways, and especially family physicians, they have to increase their earnings, and they are very reluctant to increase their fees, which is very, very sad, and we keep pushing them for that. Okay, so pneumococcal vaccine, your indications of which adults should ethically receive pneumococcal vaccine?
So anybody who is above the age of 65, okay, even if they have no comorbidities, they need the pneumococcal vaccine. Below that age, if you have any chronic disease, I mean that chronic disease can be chronic heart disease, lung disease, liver disease, renal disease. Diabetes is basically diabetes with some organ involvement. Simple diabetes, yes, may not be an indication, but otherwise that. So think of any chronic hematologic disease, whatever. They are a cancer, whatever kind of chronic illness. And actually, if you look at all the people who are walking in your OPD, I will tell you that 90% of them qualify for pneumococcal vaccine because they have some or the other chronic illness.
How many doses of Prevnar, how many doses of Pneumovax? There are two pneumococcal vaccines available in India. One is PCV13, Prevnar 13, and one is PPSV23, which is Pneumovax 23, if you brand names. How many doses of each?
One each. So basically, remember that you have to always vaccinate with Prevnar before Pneumovax. That is very important because sometimes, you know, you tell there are the two pneumococcal vaccines. Prevnar is costing 3,800, that Pneumovax is somewhere around 1,500. You should never give the Pneumovax before Prevnar because that will make the immune response of Prevnar lower. So you first always give the conjugate pneumococcal vaccine, which is Prevnar. Then the Pneumovax you give after either 2 months or 1 year, depending on the patient's comorbidity. So suppose you have a patient with interstitial lung disease or chronic cardiomyopathy, or those who are at high risk of pneumococcal infections or steroids, then you give the Pneumovax after 2 months. But let us say you have a healthy 65-year-old where there are no other comorbidities, then you give the Pneumovax after 1 year. Now, the only other exception is that if you have given the Pneumovax before the age of 65, let's say you had a patient who was 55 years old for which you gave first Prevnar and then you gave Pneumovax, then you can repeat it after 5 years or you can repeat it at age 65. No, only Pneumovax. So the first thing is whoever is a candidate, you first give the Prevnar, okay? And then after 2 months or 1 year, you give the Pneumovax, depending on the urgency of protection against pneumococcal disease. Why is it said that you give after 1 year? Because the protection is better if you give the second dose after 1 year. But if your patient has a disease for which you need urgent protection, you give it after 2 months because you must understand that Prevnar gives protection against 13 serotypes and Pneumovax gives protection against 23 serotypes. But the quality of immunity which you get with Prevnar is better than what you get with Pneumovax. So that is the trade-off between the two vaccines, and that is why both the vaccines are used in our country. Now in America, they have now 20 valent. 15 and 20 valent. So maybe when they come into our country, we may not need to give Pneumovax. That may happen later. But for now, you give Pneumovax, and maximum you can give of Pneumovax is 2 doses. Okay. So that second dose of Pneumovax can be either after 5 years of the first dose. So suppose you gave a vaccine at 55, then you can give it at age 60, or you can give it at age 65.
So yeah, there are some select CKD patients, for example, where they do recommend every 5 years PPSV 23, that is Pneumovax 23. The vaccine that she was saying in the US, now the standard of care has become PCV 20. So conjugate vaccine 20. Now this is such a vaccine where then Pneumovax becomes redundant. You don't need to give Pneumovax after PCV 20. We hope to get PCV 20 maybe in some months or years. PCV 15 came before that. PCV 15 better than PCV 13, but you do need to give the PPSV 23 after PCV 15, but not after PCV 20. I hope I am right, but this is
and
my
there
reading.
are 2 other conjugate pneumococcal vaccines like Synflorix and Pneumocil, which are available, which you give in children, but these are not licensed for adults, so you can't use them because they are cheaper than Prevnar, but they cannot, they are not licensed for use in adults. Yeah, so you actually, that is a basic rule of vaccination, that you give it when the patient comes to you and you never repeat the dose. So it's not that, I mean, the only downside for giving it after 2 years is that that patient was unprotected for those 2 years when he didn't get it. And there may be situations where a patient has already got pneumovax earlier, because you may not be the first person to vaccinate. There may be people who may have vaccinated. So in that case, the Prevnar can be given after 1 year of pneumovax. So you have to give it after 1 year. It's not that you consciously avoid giving pneumovax before Prevnar, but if the patient has inadvertently got pneumovax earlier, then you give him Prevnar 1 year after pneumovax. No, no.
After 5 years, maybe you
Yes.
can repeat the pneumovax after the first pneumovax. Yeah. Sorry, explain.
So there is a general rule in vaccination that if the patient is not sure or the patient doesn't have a record, you assume he's unvaccinated and you proceed with your vaccination. That is a general rule, because many times patients will say, I don't have a record, they don't have, then you assume that he's unvaccinated and you start with the fresh schedule.
If repeat Prevnar is given, any harm?
No harm, because if they don't have a record now, how earn? It is only that it will be extra cost for the patient at no benefit. That's the only downside.
Dr. Devesh, quickly, last 3 questions.
No side effects. No side effects.
Huh? He is asking if Prevnar is given at 55 and pneumovax 56.
Huh. Yeah, then you will give him at age 65 again. Na?
Another
You would give him.
pneumovax.
The pneumovax you would give again. No, Prevnar is only one
never-
dose.
Sir,
No,
Validity
Prevnar
of-
is lifetime validity. Prevnar you don't need to repeat again. Yeah, I think because Prevnar has just come in to the market, 20 years ago or something, that's why we don't have that cohort of people. So I don't think that answer is still there, whether you would give them or not, because most of these people have not even achieved the age of, let's say, that age when they would be candidates for Prevnar. But I think you would give, because especially many of these people would have got Prevnar 13, Prevnar 7. So when you have a Prevnar 20 which is available, you might actually give it. See, there is a difference if you look at the recommendations in the US versus our country. In the US and all the recommendations are also guided by the community benefit, because it's a national program, it is free. So if they make a recommendation for protection, it has to be cost effective. Okay, but here in India, we are talking about individual protection. Okay, so there the patient is himself paying for the vaccine. So even if you have a incremental small benefit, you would like to recommend the vaccine to the patient. So that is a little difference between if you look at guidelines from the US versus what is happening in India.
ma'am. 1 second, huh? Sorry. I'll just put the question, reframe the question for the audience. She's saying if after the pandemic COVID, especially people who have got COVID pneumonia and maybe post-COVID pneumonia residual fibrosis, do these patients also qualify for PCV 13?
They do, because if anybody has chronic lung disease of whatever etiology, they qualify for pneumococcal vaccine. You would give them.
But mild COVID, upper respiratory Omicron kind of COVID, you may not consider that as a risk factor.
Risk factor.
Pneumonia.
Yes. So actually now it would also depend on whether they have completely recovered or not, because many of these patients had a mild pneumonia and after 3 months their lung function is normal. So then in that case, you would not give, because you have to understand one more concept here, that you should give the vaccine when you need it most, because you will not be giving it again. So now if this patient at age 35 is otherwise healthy, doesn't have impaired lung function, you have given him Prevnar. But then these antibody levels are going to decline over time, isn't it? Of course, immune memory will remain. But then you have said that he has got Prevnar 1, so I will not give him again. So when he turns 55, 60, 65, when he's actually in need of the vaccine, you will not be giving it. Na? So that is why you have to be careful to give the vaccine when they need it. That is also applicable for pneumovax. Because if you have given unindicated pneumovax then when the patient actually needs pneumovax, you can't give it. Because studies have shown that if you give vaccines more often than needed, your immune response actually goes down, which is a phenomena called as immunologic hyporesponsiveness. So remember that the vaccines are not a vitamin that you can just go around distributing to everybody, because you may be then depriving the patient of the vaccine when he actually needs it.
Yeah. We'll take the last question there.
Yes.
Can
yes.
you give influenza and pneumococcal on the same day?
Yes.
Irene? Can you repeat the question?
The question is, what is the future schedule for them? So if the child has actually received Prevnar, the full doses, then this patient will then qualify for pneumovax later, as and when there is an indication. Suppose he develops a chronic disease at age 25, then you can give pneumovax. And when he becomes 65, if he has no diseases, then at age 65, you can give pneumovax.
Dr. Alpa, last question.
And there is just a rejoinder here is, it will still remain open to debate at that point in time whether he had taken Prevnar 7 or 13 and what is currently available at age 20. So that so-called taken Prevnar may not be sufficient. So it's good to have.
One more thing is that Prevnar extra doses don't harm the patient, but pneumovax extra doses do harm the patient. That is also a difference.
Dr. Alpa? She's asking if a very senior citizen comes.
Yes, yes.
You
do give, and I'm telling you, these are the people who need it, and they are the most reluctant because they feel bukhar aa jayega, pain hoga. They are very reluctant to take vaccine. So you have to really convince them. Then you would give this patient the Prevnar, and maybe after 2 months itself, you would give the pneumovax.
Which one?
Synflorix is basically a 10-valent conjugate pneumococcal vaccine from GSK, but that is now given up mostly because it does not have 19A, which is very important.
Okay, I made a mistake. I'm revising my estimate to about 60,000 rupees per month. Since she said that 80 to 90% of your patients will require the vaccine. So just a budgetary thing, 3,900 is the MRP. And you will get it at around 2,700 to 2,900 from the dealer. What would you charge? I would just ask you. Will you charge MRP? Will you give the patient discount, or you will charge a little more for giving the injection plus the MRP? MRP plus 100? More, MRP plus more, Dr. Alpa? MRP plus 100, 200. MRP plus 500 coming from South Bombay. Dr. Merchant? MRP plus something. Okay, so you are looking at a significant income, which I think is ethical, and you don't probably need to, you might be able to. Now we come to the second earning.
I will even add that it's not increasing income. You will be actually fulfilling your responsibility to your patient to give.
Absolutely. Scientific, ethical.
Scientific, ethical,
everything.
and mandatory.
Mandatory, very true. Now we come to the next vaccine for adults, which is influenza vaccine. I'm sorry we're talking about money here. She's on a fixed salary, so she probably does not need the priorities.
Right? You don't know that, right?
We don't know that, okay, we don't know that. So, so influenza vaccine recommendations in children and in adults.
So influenza, there are few concepts you must understand about influenza before we talk about the vaccine. These influenza viruses are like COVID, very mutating. So they keep changing. That is why you have to give annual influenza vaccination. And also the immune response induced by the vaccine lasts for only about 6 months to a year. So even if the composition of the vaccine doesn't change every year, you still have to give vaccination. Now what happens is that the World Health Organization connects strains of influenza which are circulating, and comes out twice a year with recommendations about the composition of the vaccine. So for the Northern Hemisphere, they come out in recommendations in March, so that the vaccine takes 6 months to bake. So you have 2 vaccines coming in every year, one in the month of September, October, which is the Northern Hemisphere, and one in the month of April, May, which is the Southern Hemisphere vaccine. Now, the question is, so that is one thing you must remember, that you have different vaccines coming out twice a year, and in some cases the 2 vaccines may be the same also, because if there has been no change. So that is one thing. But who should you vaccinate? That is the first question. So again, it is same in adults as pneumococcal vaccine. The indications are just the same. The only other thing is that in healthcare workers and pregnant women, these are 2 other categories where you must give the flu vaccine, apart from all the other patients we discussed who received the pneumococcal vaccine. Why pregnant women? Because they are, if they get influenza, it can be a severe disease. And why as healthcare workers? Because we are prone to getting flu from our patients, and we can also pass on the flu to our immunocompromised patients. So these 2 are important. Now, apart from that, in children or children under the age of 5 years should receive the flu vaccine, because they are at risk for severe flu disease. And older than 5 years, any child who has a chronic problem. Apart from that, any person can take the flu vaccine. Okay, so for example, in the US, every single person is given the flu vaccine, because the country believes that absenteeism and all the other things can be avoided if people take the flu vaccine. So if you have a 35 or 40-year-old healthy person coming and telling you that, doctor, I want the flu vaccine, so there is no harm, because the vaccine is extremely safe. So the priority groups I've already mentioned, but apart from that, anybody who desires to take the flu vaccine can take it. And if they ask you for the flu vaccine, you should give it to them. You may not recommend it to them, but if they ask you, you should give it to them, because if you say, no, you should not take the flu vaccine because you are healthy, and if this same patient goes and gets an influenza pneumonia and gets admitted to the ICU, they will turn around and tell you. So what I'm just trying to say is that anybody who wants to take the flu vaccine can be given the flu vaccine. There's no downside, but there are certain groups where you have to yourself recommend it to them. The second is when to give the flu vaccine. So when to give the flu vaccine depends on when is our flu season. So when is our flu season? In Mumbai?
Monsoon.
Monsoon. So we have flu throughout the year. It's unlike the US, where you have the flu season lasting from maybe October to March. Our flu happens throughout the year, but the maximum is seen in the monsoon, starting May and June. So you have to give the vaccine which is the newest in that sense. So that means which is the vaccine which is available in May and June? Southern Hemisphere vaccine. So you give them the Southern Hemisphere vaccine. But now let us say you have a situation when you are, let's say in November, December, you are sitting in your clinic and you have a patient who comes to you who is a candidate for flu vaccine. So are you going to tell that patient that come again in May and I will give you the flu vaccine? The answer is no. You will give them the vaccine which is available right now, and then tell them that from now on, every year in May you come and get your repeat flu shot. So if you've taken a flu shot in November, you don't need to take it in May again. But suppose you have a person who needs the flu vaccine who has come to you in the month of March. Then maybe you can wait for a couple of months, because then you will be able to give him the new flu vaccine. Now sometimes you can also go and check the composition of the Northern Hemisphere and Southern Hemisphere vaccine on the websites. Because that is available. And if you find that the Northern Hemisphere and Southern Hemisphere vaccines are same, then you can even vaccinate that person in March with the Northern Hemisphere vaccine, because you know that 2 months later when the new one comes, it is going to be the same. So generally speaking, you should give them in the month of May. But if they have come to you in October, November, give it to them then and ask them to come every year for the vaccine. 1 year. So unless you have a patient who is like severely immunocompromised with severe ILD, that patient you may even vaccinate 6 monthly. But otherwise for other people, elderly people, chronic diseases, every year, once a year.
Oh, she's a little confused about the dates, which she's rightly saying that somebody took a vaccine in October or November and should take the Southern Hemisphere. Then 1 year would be next October. So southern
No,
hemisphere.
no, 1 year from the southern hemisphere vaccine, because we should align our cycle of influenza
again,
vaccination with this. So if you have taken in October, you give it again in May, and then you give next May.
Every May.
Every May. That is the time when you tell your people to come back for their vaccination.
I think we should be clear about this, right? We need the southern hemisphere more than the northern hemisphere. We need to therefore put an instruction every April, whoever desires or who have comorbidities will come in April or May, whenever the vaccine arrives for us, and take the vaccine. Right? This should be the norm. Everybody should be told. And in April, you please start ordering your vaccines.
And you know, it should be a proactive or a preemptive strategy, because many people think, अरे फिर वो पेपर में पढ़ते हैं कि flu के cases आ रहे हैं, then they come for the vaccination. That is a reactive strategy which should be, you give it, but you must remember that after giving the vaccine also it takes 4 weeks for the immunity to build up. So if you have an ongoing flu epidemic, then how are you going to take care? So that is why it should be in anticipation, means you are doing your health check every year or whatever things you do every year, it's like that you take the flu vaccine every year.
May I give a practical suggestion? How many of you have WhatsApp on your phone? Almost everybody. How many of you get messages from patients on WhatsApp on your phone? Almost everybody. How many of you have made WhatsApp groups or broadcast groups of patients? Only very few. Please do that. If you have numbers of your patients, because they message you anyway, make broadcast groups. It is a time-consuming thing, but maybe some assistant or somebody can do. Make broadcast groups of your patients. And every April, for example, in this situation, send a broadcast that a new vaccine will be available for influenza. We recommend it that these people must take, and the others have a choice of taking whichever. Please do that so that the patient, as she said, you have to be proactive. And this is proactive. You are telling them to take. Yeah.
If you're using some software, then you have an option to send a message through that to all your patients or as per the age group of that patient.
Outpatient software, which some people
software
use,
if you are using.
medicine software.
In fact, you can go a step ahead. So if you have an elderly person who has multiple problems in the house, then you can even recommend cocoon vaccination. That means all the other people take the vaccine so that they don't transmit it to that person. So you can even go a step further. Because sometimes, people come, हमारे ये 2 बहुत elderly parents हैं, उनको बहुत बीमारी है, हम क्या कर सकते हैं उनके बचाव के लिए? तो आप ये भी बोल सकते हैं कि आप उनको तो वैक्सीन दो, पर आप भी अपने वैक्सीनेशन से up to date रहो. No. Only if their asthma is severe enough that they they're on off and on in oral steroids then, but otherwise no. They are not at risk. So, adults.
She's asking if asthmatics are at risk in children and adults and therefore qualify for vaccination.
So, there are some studies which have shown that the influenza vaccine does not really reduce the number of asthma exacerbations. So, your decision about an adult will vary on the severity of their asthma. So, if they're having COPDs and other things, then they definitely qualify. But if you have a patient who gets a once in a year, he doesn't qualify for the vaccine. And also, you must tell the patients why are you giving them the vaccine? Okay, because you say that the vaccination is to protect you from severe influenza which lands you in the hospital. The vaccination is not to protect you from the regular upper respiratory infections which you get, because otherwise they will turn around and say, I took the vaccine and I'm still getting these cold and coughs. Because you have to tell them there are multiple respiratory viruses. We are giving you the flu vaccine which protects you against one virus, and we are giving it so that you don't get the influenza pneumonia. Because we have so many parents coming that my child keeps falling sick every 2 months. Can I give the flu vaccine? So you say, yeah, you can give the flu vaccine, but don't expect those number of infections to come down.
Because you give an influenza vaccine and after 1 month your diagnosis will be viral flu. Okay, and then you will have to answer. So before that, it's good to prep them that not only that, but even for influenza itself, it's not 100% protection like most other vaccines.
Last question, yeah. Sorry? Always tetravalent vaccine?
So now the trivalent is no longer available. You have only the tetravalents available, and the nasal vaccine which was used earlier is now given up because of the poor immunogenicity. Also, You have various brands of, can I tell a little bit about the brand also?
Absolutely.
Yeah, because it is commercial, but you have various brands available like from Sanofi, from GSK, from Abbott, but the one which is from Zydus Cadila is significantly cheaper. So sometimes if you have a patient who has they are this, then you can even go for Cadila.
What is the brand name?
Vaxiflu.
Vaxiflu. Okay.
Yes, so it is
Vaxiflu
cheaper because
Tetra.
all the other brands are costing around 2,000. This one
And
is
this
cheaper.
would be how much?
800,
rupees.
yes. So that is an indigenous vaccine, and it is also tetravalent, and it has the same composition as the other flu vaccines.
But again, to you, the cost comes to around 1,000 rupees or lesser. I'm not sure of the other brands as well. We are not competing for brands here.
No,
We're
I'm just
saying,
telling you because sometimes, you know from your patient that yes, it will be easy because then you should, even though the margin of profit to you will be less if you use that brand, but I think sometimes you have patients where you must pass on that benefit.
On that note, now gone are the days where we can say for any child that the patient is not affording, so I did not give an injectable polio or an XYZ vaccine because it is freely available for free and freely available in government setups. And they are really very well managed centers, at least here in city of Mumbai.
That is the primary vaccination.
Primary
which is approved.
vaccinations. Primary
Not
vaccinations.
influenza.
No, not influenza. Not influenza.
Correct. The next vaccine that I want to discuss with her is another one which is used both in pediatrics and adults, and that is for HPV. What are your recommendations in HPV vaccination?
So HPV, so actually speaking, all girls between the ages of 10 to 18 should get the HPV vaccine. And the earlier you give it, the better it is, because many times parents have this that uske periods nahi aaye, to nahi dena hai. But if you give it at 10 to 12, the immunogenicity is better than when you give it later. Also, if you give the vaccine below the age of 14, you need only 2 doses, as against after 14 when you need 3 doses. So it's always better to finish your vaccination before 14 for the HPV. Now, you can give catch-up vaccination up to the age of 25 years. So the benefit is most, and you must remember that HPV has to be given before the person becomes sexually active. Because if the person has become sexually active, then they get infected, and once you're already infected, then the vaccine does not protect you. But you actually don't know whether the person who has become sexually active is infected with the 16, 18, which are the ones which cause cancer. So you can still give them. Okay. So the thing is that ideally the vaccination should be given before onset of sexual activity. That is why at 10 to 14, but it can even be given to sexually active females, but we don't know how much benefit it will offer. Now, catch-up vaccination can go up to age 45, okay? But really, the benefit of giving the vaccine beyond the age of 25 is not too much. So I think as per guidelines and as per recommendation, the vaccine is best given till the age of 25. If somebody beyond 25 wants to take the vaccine, you can give it to them, but you don't know how much the benefit. Those are the patients you must recommend pap smear, okay? Because that, and it is, even if you've given the HPV vaccine, pap smear is mandatory. And then you have now 2 types of HPV vaccines available. One is Gardasil and the other is Gardasil 9. Okay, so Gardasil plain is covering 4 serotypes, 2 which cause genital warts, 2 which cause cancer, and it is costing about 3,500 or so. And you have Gardasil 9 which has more serotypes, which gives better protection against cervical cancer, but it is costing about 11,000. So therefore, there is a significant cost difference between the 2 vaccines. But if you have a candidate who is a candidate for HPV vaccine, you must not make that decision yourself कि इसको Gardasil देते हैं, इसको Gardasil 9 देते हैं. You must tell them that these are the 2 vaccines which are available. This is the benefit of this versus this. You can choose which you want to give.
And both will be 3 doses.
No, if it is below 14, then it will be 2 doses.
But otherwise, between Gardasil 9, there's no dose.
Dose difference, yeah, it's the same. It's 0, 2 and 6 months. 0, 2 months and 6 months. And if you are giving 2 doses, that is 0 and 6, the second dose can't be given before 6 months. It can be given any time after 6 months. Many times you have people who come, who have started the schedule, then they have lost. वो बहुत बार COVID के time में they started it before COVID, then they lost. So then you have to count the previous schedule. And if your patient was below the age of 14 when they got the first dose of Gardasil, then even they are 16 right now, they don't need 2 doses, they just need 1 dose.
One more dose, yeah.
Yes.
If they have taken the first dose as HPV 4, can we move to HPV 9?
No, that is not recommended. So now they first took the normal HPV and now you have the 9 valent, you can't change.
If the parent is saying, I'm ready to do the full course of HPV 9, is it
There is
okay?
no
And whether
data
there is any
actually.
gap required or?
I don't think, I haven't looked at it, but critically, but there is no such data available that a person who has taken Gardasil or the HPV4 should now, because the new vaccine is available, should take that schedule again. There is no recommendation.
No, not should, but as you said, I am the paying parent and I say, okay, I want better protection, like how we gave 7 and now I want to give 13.
But it is not licensed there. There is nothing in the licensor. So you have to be careful about that. Because, there is a lot of misinformation on WhatsApp also about this. So now suppose somebody has taken 2 doses, then you give 2 more doses and patient lands up with some problem later, some autoimmune problem and all. They might, because you have to remember that you must stick to the labeling instructions for the vaccine. If that labeling instruction is not there, then you should not really give it even if the person wants to take it.
Is Cervarix useful at all?
Yeah, Cervarix is also useful because it gives almost the same protection cervical cancer as Gardasil, as the HPV4. The only thing is it doesn't protect against genital warts. That's the downside. But it is cheaper.
And some parents come and ask that my cousins in the US, they are given to the boys also. Should we be giving to our boys to protect our?
In India, it is not it is not got the approval for boys. So in India, HPV vaccination is not approved for boys. But we must understand why is HPV given in the US for boys. It is not for the protection of the boys. It is for protection of the girls because boys will transmit the infection to girls. Now we know that HPV protects against penile cancer also. But that is not an indication why we would give it to boys because the risk of penile cancer is very low. Now there is a population where we are vaccinating with HPV in India, men, and that is men who have sex with men. So they are themselves coming forward to request for the HPV vaccination because they are concerned about warts. Because that can be quite a nuisance and all that. So there we are giving it off-label, men who have sex with men. From the second dose.
She's asking if the first dose and second dose are given in time, 0 and 2, but the 6-month dose is not given in time. Can you give the 6-month dose later and count the first 2 doses?
Other way around, she's asking. She's saying the second dose is delayed, whether the third one will be after 4 months or?
Yeah, it will be, you will count it from the second dose, not from the first dose. So you will not shorten the interval between the second and the third dose to make up that schedule. Because if you give the vaccines at a shorter interval than what is recommended, you reduce the immunogenicity.
She's asking if there is cervix cancer in the family. Should the, daughter get HPV 9, the costlier Gardasil, than the cheaper
I
Gardasil?
think, genital cancer means whether it is endometrial, ovarian or cervical. Now we know that HPV only protects against cervical cancer. And the cancers which are genetic are mostly ovarian and endometrial. So, but there is a psychological aspect to it. So you can put it forward to them and then let them choose. But you would not proactively recommend because cervical cancer is not genetic, unlike ovarian and endometrial cancer.
And it's very important what she said is because it's not just about telling the vaccine. It also means that you are telling the patient you are more at risk when you are actually not more at risk. You get my point? Cervical cancer is not genetic. But if you tell the patient that because your mother had it, you are more likely to get it, so you should take HPV.
Yes, sure.
You are increasing the anxiety level of that patient of getting a cervical cancer, which she is not.
cervical cancer 3 doses.
Cervix, if it's below 14, then 2 doses, above 14, 3 doses. So it doesn't depend on the type of vaccine, it depends on the age. If you're below 14, whatever vaccine you use only 2 doses.
One minute, Dr. Rashmi.
Yes. Sorry, what did she say?
Can you repeat that? So again,
Yeah,
same
yeah.
question.
Yeah, you can give it whenever they come to you. So you have to count the first dose as given. You don't have to restart the schedule.
So it can be 0, 6, 12 also. You can be that.
Kitna bhi. That is a basic principle of vaccination because of immune memory. Even if they took the vaccine 5 years ago, it will be counted as taken if they have a record. And you have to proceed from the second dose onwards.
Okay, I think
Cervarix, the dose as the schedule, as you were saying, originally was above 14, 0, 1, and 6.
And this is 0, 2,
Gardasil is
6.
0, 2, and 6.
You also have an abbreviated schedule, like 014 or 024, because sometimes, they are vaccinating the children, the child will go abroad for studies, they don't have that 6 months, so you have a schedule where you can prepone the third dose to 4 months.
okay,
But
I think
it's always better to postpone rather than prepone for the vaccine. So if they insist, you can do that. But you know that the third dose can be given between 6 to 12 months very easily. So usually they'll come back in 12 months. For student population, I'm saying.
The only advantage is that Gardasil gives protection against genital warts also, which Cervarix doesn't do. So if your objective is only for protection against cervical cancer, then I would say that your Gardasil 9 is the best because it gives the best protection.
And I don't remember, but I think Cervarix costs much lesser than
Yes,
Gardasil.
yes.
So that's why some people still prefer Cervarix.
2,500, yes.
a new HPV vaccine has come out, which is even cheaper.
Okay.
It will be less than 1,000 rupees.
Okay, I don't know about it. I'll have to look at it. Yeah.
So we only read in the papers. We haven't seen any data on it.
Yes.
I don't myself. Yeah.
Yeah.
Has it come in the market, the Serum Institute vaccine?
No. But yes, please remember that the Serum Institute is an excellent company. Their credentials are good. So if they have a vaccine and you looked at the data, then even if it is cheaper, you can obviously use it. Because it is much better to vaccinate more people rather than, vaccinate fewer people. Yes.
Sorry, do you have?
Zoster.
Herpes zoster.
So we'll discuss the herpes zoster vaccine after we take a break. And we take a break. उसके पहले 4 lines सुना देता हूँ. I'm trying to learn a language which is called Hyderabadi Hindustani. Hyderabadi have a very typical. So उसकी 4 पंक्तियाँ हैं which is relevant to today's talk also. कि एक there is a खामखा हैदराबादी करके एक हास्य कवि हैं. उनकी पंक्तियाँ हैं कि मतलब के सब लोग हैं. मतलब के सब लोग हैं. यहाँ कौन तेरा दुख बांटेगा? ऐसा कोई दोस्त नहीं जो तेरी खांसी खांसेगा. किस्मत में कर लिखा है पेट पे इंजेक्शन लेना. ऊंट पे बैठ को निकलोगे तो भी तुमको कुत्ता काटेगा. We'll take a tea break rapidly and come back.